And the second part of the study was the focus groups. I'm a qualitative researcher by expertise, so this was my favorite part of the study because this was talking to the nurses. And numbers are numbers, but when you actually went into these hospitals and talked to them was to me the most telling of a lot of the project. We did 6 focus groups at 6 different hospitals throughout the state of North Carolina, literally the coast, the mountains, and the central part. 4 were community-based hospitals and 2 were large teaching hospitals. And we did focus groups first with nurses that were working with depression and or pain that declared that. The other groups were nurses that were healthy but worked with these nurses. And then the third group were managers, nurse managers that were responsible for nurses with health problems. And what we found from all the focus groups in the analysis is that nurses' health impacts all nurses, not just the nurses that are unhealthy themselves. And in fact, most of the telling stories came from the nurses who were working with them that quote unquote were dumped on every day and were not getting any acknowledgement for the extra work they were picking up with. All the groups talked about quality of care and safety being impacted. The stories they shared were pretty horrific about nurses that couldn't do any turning of patients, that wouldn't walk elderly patients anymore because they were afraid they would get hurt trying to walk someone with limited mobility. Young nurses that had no one to help them turn patients in bed because all the nurses said, my back hurts, my rotator cuff, or something, and they weren't getting any help on the unit, especially in critical care where there's very few nurses. And the nurse managers basically said, this is very scary, there is no problems because all my nurses work as a team. And the nurses that don't have health problems are helping those nurses that have health problems. So there really isn't any problem here. And another very glaring thing that came out of this focus groups was no one has any knowledge. They did not know what their hospital policies were about worker health or what they could get. The managers especially said, I'm afraid to talk about health. I could get sued. I don't know what the, any of the occupational rights are. I don't know what I can write on a job evaluation, anything other than they do their job or they don't. I'm afraid to address this. So it's like the white elephant in the room. Everyone knows it's out there, anyone that's been in the workforce, and everyone's kind of afraid to talk about it. And the nurses without the health problems don't want to offend these nurses. They're trying to kind of support them sometimes. And the nurses with the problems are just trying to get through the day. And now that the economy has gone down, they're actually a little bit afraid of even reporting anything because they're afraid they could lose their jobs. It's no longer a shortage, at least in North Carolina. We have quite a few of our new graduates that aren't able to find jobs this year, which, of course, with the secular nature of shortages, this too shall pass. But for today, we no longer have an acute shortage like we did. So what? Well, first of all, the aging of the workforce, increasing stress, most likely increasing economical cuts, are going to lead to more unhealthy nurses in the workforce. That's just a given. It's going to happen. It's out there right now, and it's probably going to increase. Nurse health and presenteeism, which is that productivity impacting their care, is impacting quality of care and patient safety, and that is not being addressed in any way with all the other things that we talk about impacting care. And very importantly, there's a general lack of knowledge about what to do and how to manage it in the workforce. So now what? Getting the word out. And that's exactly what we're doing here today. And different speaking engagements. The qualitative study's already been accepted for publication, and it will be out in April in the Journal of Nursing Administration. The other manuscripts are in progress and under review. I'll be presenting at NDNQI in January. For anyone that is going to be there, you may hear a larger version of this in Miami. I don't know how many are competing against us, but we did submit a NPSF grant last week, and I'd like to thank Heather. One real benefit about being an inquiry-funded person is I get information I wouldn't have known about. And Heather sends these great things like, there's a grant, it's due next week. And you're like, but it's really been, to me, an incredible resource to even be put on blogs and know things that I wouldn't have been aware of that I can disseminate to nurses in my agency and throughout North Carolina. And the next thing is designing interventions. I think we've described it, and I think a lot of funding agencies are sick of the description of all the problems. And it's now really time to do some interventions to see what we can do to try to fix it. So our next project is really looking at an intervention to see how we can help some of these nurses with these issues, and if we can help them, will it improve their ability to give quality care? And that's our study, so.
Are there any questions?
I just wanted to go back. This is very, very interesting. And I just want to go back and clarify or affirm that with your basic population, those were just nurses who were licensed or registered, or just the sort of capture average nurses?
Right. The quantitative part of it was a North Carolina Board of Nursing list that they were able to randomize to only nurses that are in direct patient care, working in hospitals.
And so then, what was it, 70%, 7 out of 10 said that they
work with some degree of pain on any given day.
Out of all the nurses in North Carolina?
That were in the random sample of 2,500, 70% directly in patient care in a hospital setting said they are working with some kind of pain.
That's, I mean, stunning. I can't say it's unbelievable because you just affirmed it, but that is just
and
like...
Actually, Trinkoff has done a lot of work with back pain and reports that up to 75% of nurses have back pain or work with back injury. I mean, that's kind of out there. I was more concerned about the 18% depression.
Well, that too.
Because the national average is 9% in a general cohort, so we're looking at 18%, and that is on a depression scale. There were other nurses, we asked what health problems they had, and a lot wrote depression. So we don't know if they were so treated that they no longer scored as clinically depressed. So there may even be more depressed nurses out there. And, you know, actually the nurses in the focus group said the depressed nurses were almost harder to deal with because they sucked down morale so bad. And, I mean, that's a quote. Barbara?
Maybe I misunderstood in one of your last slides, but I hope your conclusion wasn't that there's nothing that we can do here. And in fact, and I'm sure not.
Everything will have a positive spin, and that's the other. I want to thank Barbara for letting us publish in her journal and getting out our little inquiry cohort got a lot of exposure there. But to put the positive spin on it, the last thing we need is for nurses to be looked at as dangerous. And the issue here is how are we going to help them, because they're like everybody else. Why shouldn't we have health problems?
Because in long-term care, obviously this is somewhat of an old issue, no pun intended, and a lot of focus and intervention has gone into workforce and safety and health. And just to give you a great example, we just rolled out a worksite health promotion study totally focused on the nursing assistants. My agenda, of course, is to engage them in physical activity, so they'll do it with residents. But the response on the part of the nursing assistants and their willingness and excitement about this has been phenomenal. And if you think about things like gymnastics, you have to prime your body to be ready to do some of these things. And none of us should lift a patient if our bodies are not physically in condition, but they could get there. So there's a lot of exciting intervention work I think we can do from that perspective. So I just wanted to make sure it wasn't no, they're just unhealthy, let them eat donuts.
I noticed on your PHQ-9 that you said there were 18% that had 10 or higher, scored 10 or higher.
For clinical depression on that is a 10.
Right.
I've seen it used other ways, that you can have mild depression with like a 7. But we actually use the clinical depression cutoff as 10. There are people that scored much higher on the tool.
Yeah, I think it would be helpful to know the standard deviation in the range, because your mean was 5. And so that means to me that at least 50% were not depressed. And the other thing is, on that particular instrument, it's very useful if you take the last question, which indicates whether or not somebody is having any kind of suicidal thoughts. And there's some scoring of that combines the overall score with that last question and gives you much more information.
Thank you. And that's one thing, they always say, what did you learn from this project? One thing we learned is not to use single point measures. you know, and I'd actually even like to put a social desirability scale into the next survey design to see if they're trying to answer, and I think that's like a great, and someone told me that when I was talking about the study. What a great thing to see if you can correlate, are they just giving you what they want? So we did learn that, and that is a valuable lesson.
Well, it may, also in the next study, you might think about using the Maslow's burnout scale index, which is really widely used, and particularly in nurses, and you've got some norming possibilities, and it gives you a lot more information about how nurses are responding to their work environments.
Thank you.
Hi. It's a sensitive question, and perhaps you mentioned it and I missed it, but was there an association between age and presenteeism?
Yes. And I will tell you,
in the expected
preliminary work, the study that I had done before this, which led to putting this grant in, was just a simple, nothing's ever simple, but looking at the impact, what impacts productivity, and age was one of the first things, and age actually correlates with health problems too. It's not a surprise.
Right. Okay, thank you.
You, on the cost figures that you showed for associated presenteeism, did you generate those on? How did you generate the dollars? Was it like the average cost per fall or the average cost per medication error?
Well, for example, and I'm conveying this what Chris did, the economist on the team, and let's say pick fall, and citing some references, he says that each fall, because of additional hospital costs and other things, he comes up with a number of $583 per fall. Now, even if you assume that number to be an accurate number, I didn't challenge it, but there were a lot of other things that were going into the calculation of the cost impact. So this $583 per fall, you know, you just have to take, you know, Chris's word on that. But let me, if you want, I can tell the story beyond that, like what else is happening. It turns out that on the number of falls per 2-week period, the mean score was 0.0415, so hardly anything, 0.0415 per 2-week period. That's the average on that variable fall. But if you convert that to per year, so multiply that by 26, and all of a sudden it begins to look like 1.1 fall per year per nurse. And now the numbers are beginning to add. So 1.1 fall per nurse per year. And then there is some, there's a 24% adjustment which is done, so that bring the number down from 1.1 to only like 0.259 per year. And we can talk about that that reduction that was done. But he is bringing the number of falls per year down to 0.25 per year. And then he brings in the underreporting. For example, this is a serious issue now.
Moving towards more independence.
It's not like, you know, well, this could have legal implications. You could lose your job if it turns out that, yes, and I'm speaking as an outsider. If under the care of a nurse, somebody falls, you know, it's a serious business. So the question is that, well, what do you do about the underreporting? So there was a question on the survey, that is, what do you think, what extent of the time you think your colleagues are underreporting falls and medication errors? And it turned out that based on that question, there was a 34% underreporting. So this number, 0.259, was revised upward by that factor, 34%. So finally, we got a number of 0.348 falls per year per nurse. Now multiply that by the $583, which was the cost per fall, and multiply by the total number of nurses, and you have the total impact. And that's the impact from falls alone. Right. And similarly,
and the others were generated in a similar way.
Right. We have more information on medication errors because it increases length, so that one's a little easier.
Okay, I guess that's it. Thank you very much, folks.